the number of contraceptive users. I think of these efforts as focusing on the front door, welcoming women to the many benefits of family planning use. And we know it takes a lot of effort to welcome these users. A solid enabling and policy environment to set the stage, adequate resources, quality services, strong supply chain, appropriate messaging, and community to support, to mention only a few of the inputs that contribute to successful family planning programming. But for all the effort that goes into increasing the number of new users, that welcoming committee into family planning, we should be equally concerned about the number of users who discontinue use. While some women stop using because they switch to a different method or because they want to become pregnant, a large percentage of new users discontinue for reasons that might be avoided. I refer to these women who unceremoniously discontinue use of family planning as leaving through the back door, which gets very little attention compared to that front door. Our policy forum today focuses on how to better address the issue of discontinuation. The Health Policy Plus project is wrapping up a 9-part blog series on contraceptive discontinuation, thinking about how we might be able to do more to help women achieve their reproductive goals. In this series, we explored a variety of ways that health systems could be used to address the challenge of contraceptive discontinuation. Our focus today is largely on the policy environment and how it can be harnessed to better respond to discontinuation. Of course, policy and services go hand in hand, and some of the solutions we will discuss today have their roots in the policy world and rely on effective implementation and programs to achieve their goals. Before jumping into our discussion, let me share some of the data that Rebecca Ross, our colleague from HP Plus, included in her blog on data around discontinuation. Most data come from retrospective surveys such as the DHS, MIX, and PMA. While definitions may vary, let's think of contraceptive discontinuation as starting a method and stopping it within a year. Drawing on the DHS between 2010 and 2020, the slide that's now on the screen shows the key reasons for discontinuing. The highlighted lines are reasons that can be addressed through better policy and program implementation. Side effects and health concerns are the most common reason we want to consider, while becoming pregnant or method failure is the second. Surprisingly, husband's disapproval, access, cost, and availability to the user are much less important. With access, availability, and cost, users who discontinue may already have overcome these barriers in the first place. Thanks, Georgie. Today, we'll be talking about how policymakers, program implementers, and family planning providers might address some of these reasons for discontinuation. It's a pleasure for me to introduce our 4 family planning experts from around the world. Sarah Stratton is director on the Health Policy Plus project. Sarah is a director at Palladium, where she's worked on the Health Policy Plus project and serves as director of both the Malawi Momentum Project and the Uganda Health System Strengthening Project. Sandra Mapemba is the country director for the Health Policy Plus project in Malawi and previously served as technical deputy director of the project in Malawi. Rahal Saeed is a senior program manager at Palladium on the NPI Expand project and previously served as country director on the Health Policy Project in Pakistan. And Heidi Quinn is project director on the Women's Integrated Sexual Health, WISH project, and works for the International Planned Parenthood Federation. So panelists, welcome. It's great to have you with us today. Look forward to a great conversation about different aspects of discontinuation and what we might be able to do to reduce the frequency of it happening. So let's start off with a big, broad question because discontinuation is a big, broad topic. There's lots of ways it can be remedied, but how could the types of policies that we currently have in place be revised or better implemented to reduce continuation? And in which areas do you think greater investment is needed to change the direction of discontinuation? Sarah, do you have any thoughts?
Sure. Thanks, Jay. It's great to be with everybody. So I know that you listed on that slide a number of reasons for discontinuation, and availability, access, and cost was sort of at the bottom. But I just want to reiterate that those were reasons of women's responses. So I think when we think about policies, we still can do a lot more to help women stay in the room or in the facility, or as you use the door analogy. And I think some of the policies around universal health coverage and cost are some that we can strengthen. For example, cost structures that women have to go to facilities. There's an opportunity cost there for them. Very often they end up having to pay for both the service and the method. So if we can continue to evaluate those policies, as well as looking at UHC schemes and trying to make sure that all the methods are covered for family planning, I think those are a couple of ways that we could help, as well as making sure that women can access methods in a variety of different settings beside just the facility. Thanks.
Great. Thanks, Sarah. Sandra, any thoughts based on your experience in Malawi about what we might do at the policy level to revise or better implement to address discontinuation? Sandra, we're not hearing you. Clearly your mouth is moving. While we work on that, what about you, Rahal? Any thoughts on policies being revised or discontinued? And perhaps Georgie can help Sandra address the technical issue. Rahal, thanks.
Thank you, Jay. So I think from my experience, especially in Pakistan, one of the big issues is ensuring that policies are actually implemented. So when policies are set up, they need to have implementation plans, they need to have budgets set aside to be able to implement them. Pakistan is an extremely over-legislated country. We have legislation for everything, but it is rarely enacted. So I think to me, that's one of the biggest things, that policies might exist, but then we have to make sure that they are actually implemented all the way down to the ground level. Thank you.
Any thoughts, Rahal, on additional investment? If you're able to say we need to put more money into a specific area that might kind of improve the situation or reduce the frequency of discontinuation, what might that area be?
Well, I guess investment needs to be done at every level. Capacity strengthening is a big one, especially there needs to be a greater focus on strengthening capacity at the field level. And this is not anything new. These are all conversations we've been having for years. But I think that, governments, whether they have expansive budgets or limited budgets, need to start paying more attention to strengthening that field level capacity.
Okay, thanks, Rahal. I think that's a great point, that capacity on all levels around the different aspects, I'd say, related to service delivery in particular. Heidi, what are your thoughts?
Thank you, Jay. Coming from a programmer's perspective, and wishes in 12 African countries and 3 Asian countries, I do think we have to start at the top and hold governments accountable for some of the commitments they've made to the Maputo Plan of Action, ICPD, policies that support women's sort of bodily autonomy, which supports their right to choose family planning and how many children they have, and including their method of choice, even if that be a permanent method. into preparing for this this webinar, I think sort of policies around task sharing, policies around self-care, access to information, and female empowerment against often conservative social norms. These are kind of policies and strategies that we need to put more work and more investment in.
Thanks, Heidi. I like that you bring in that it's not just about family planning policies, broader topics like policy, women's empowerment also need to be addressed. So thank you all for kicking off our policy forum by sharing your thoughts. One of the key reasons for discontinuation is side effects and health concerns. How could policies and guidelines be improved and implemented to better help clients in counseling, method use, and follow-up in order to avoid discontinuing for reasons of dissatisfaction with the method? Heidi, any thoughts?
Thank you, Jay. Yeah, as a programmer and a nurse and a midwife, I'm very concerned about the quality of services. And I think we do need to hold governments and ministries of health accountable to making sure we have the right resources to give high quality family planning services, and that includes funding to train people, funding for equipment, funding for commodities so that women can choose from a broad method mix, and then perhaps they'll get the method that they want. As we know, discontinuation due to side effects, inconvenience of the method, and health concerns accounts for 26% of discontinuation, and 32% of women discontinue because they desire to get pregnant. So we've got to get it right in the clinic. That means a well-equipped clinic with a good provider who's well educated on all the methods and the side effects, who's prepared to engage in a two-way conversation with the client to understand what their fertility intentions are and what their lifestyle is, and that will help them to get the method that they want. And with minimal side effects, and also helps them to understand that even if they have side effects or concerns, those can also be dealt with by the provider. I think we also need to make sure that there is a client satisfaction loop and feedback within services. This helps us to understand what women want, how they want it, where they want it, to do with waiting times, confidentiality, etc. But it also helps us see the gaps in the service that we're providing. So it's really important to ensure that providers are also well trained and well resourced. And this includes being able to task share methods down from doctors to nurses, and nurses to pharmacists, and pharmacists to community-based distributors. Task sharing of long-acting and reversible methods will also give women a bigger choice, so they get the method they want and that suits them, and highly effective choices, which can be useful even for women who do have infrequent partners or sexual activity. Therefore, they've got a method that's low maintenance and low side effects. Thank you.
Thanks, Heidi. I think that you've hit on a lot of the different reasons that women discontinue, and it's not just the side effects, but really boiling down to that relationship between the provider and the client, and ensuring that it's not just focused on that giving a method, but really taking the client's needs into account and looking at the life course. Sarah, any thoughts on counseling, method use, and follow-up that might be better improved to reduce discontinuation?
Yes, thank you, Jay, for that question. And I wanted to build a little bit on what Heidi was saying. She talked really about the service quality, and just to sort of unpack some of that a little bit. Counseling has been sort of a thorn in the family planning community side for decades. I mean, it's the same here in the US, really, in terms of really that engagement, as Heidi was talking about, between the provider and the client, and the client's partner, if that person is along. So I think if we need to do some more work about how to really set up the system such that providers are really sort of rewarded for strong counseling skills. And I know that that's a sensitive area. We certainly don't want to bias clients. We want women to be, and their partners to be able to choose voluntarily which method, when, etc. But I do think there are some things around rewarding providers, also in terms of looking at how countries have experimented with performance-based financing and setting that up to try to make sure that there are different types of options for countries to invest, to resource, as Heidi was saying, those facilities. She touched a little bit on task sharing and self-care, and I would add into that sort of the policies around advanced provision for pills and injectables, for example, which can again help women sort of minimize these opportunity costs that they endure in terms of going and coming to facilities. As well as if those then methods are available through their pharmacies or through community health workers or community distributors, as Heidi was saying. So many countries have such policies, but we need them to kind of be also harmonized across the policy environment so that providers are trained and are trained up to their scope of practice, that the methods are there, and that's in the country's policy, and then women can actually get the methods that they're really hoping for. Thank you.
Thank you, Sarah. When you're talking about that intersection of, the financing, like a results-based financing and rights-based, ensuring that they don't tread on each other or that the financing doesn't tread on the rights. It reminds me of the work that we're doing on HP Plus that will be presented next month at our end of project event that looks at, how do we ensure that for a given mechanism of financing that the rights are upheld. So thanks for drawing that link. Sandra or Rahul. Sandra, we didn't get to hear from you on the previous question about, what do you see as being the types of policies that need to be revised or better implemented? I'm hoping that we can hear you now. So if you want to jump in and share your thoughts on that, I'd welcome it.
Yeah, hopefully you can hear me now.
Yes.
Great. Okay, so hi everyone, and hi Jay. I think for Malawi, we've learned some bittersweet issues with policy, and especially on the discontinuation front of things. First and foremost, I think what we often miss out from the policy piece is really talking to the women themselves and seeing what they would want from us, and how we should deliver services and where we should deliver services. And so I think that's a critical piece, especially when we rolled out the Soyana, which we'll talk about a bit later on. We saw the discontinuation there simply because, we had our policy hats on and we didn't engage the women themselves to hear that. So I think it's really critical when we are doing this revisions and when we are implementing to either check in before we kind of finalize some of the documents, because we see, agency is another issue that we often overlook, especially as we go into self-care. That's going to be critical. And how do we build that agency? But in also the tight physical space, when building agency, we don't want to waste product. How do we, build in placebos? And so those conversations also need to be had. Yeah.
Thanks, Sandra. You used a phrase that I think is really important. You said we had on our policy hats, but I think that it's really important to be aware that, people like us tend to wear our policy hats, but in the decision-making process, we need to be thinking about lots of different hats. So, certainly there's the client, there's the provider, there's the ministry, all of these different perspectives. But I think you hit the nail on the head in terms of understanding what clients want, what women want, so that the way policies are developed and especially implemented reflects what they are looking for in terms of methods, uptake, and what it takes to help them continue with using family planning when they want to avoid an unintended pregnancy. Any other thoughts on this? So community support and partner support are critical to the uptake of family planning and to ensuring that women can continue to freely use the method they choose. How can family planning and health policies be designed and implemented to advance more positive social norms, such as supporting women in using family planning, that agency aspect and empowerment, fostering greater partner and community support in family planning and in health in general? I think that, this may be something where we don't want to just silo family planning around community and partner support. We want to look at health in general. Rahal, any thoughts on this one?
Thank you, Jay. Yes, I do have some thoughts. I think actually just going back to the previous conversation, when we look at community-based interventions or community-based policies, we are finally now starting to talk about human-centered design approaches. And it's really important to start with those and also to use gender rights and women's agency as a starting point. Also, then when we talk about the community level, the other thing that I find really ironic when we talk about family planning is we never take male responsibility into account. It does take two to get pregnant. So, and yet at the service delivery level, as we've been saying, as has been mentioned in many of the blogs also, the focus still ends up being on women. We are finally talking about male engagement, but I think we need to step that up a notch and take it up to the notion of male responsibility. So to me, those things are really important. Then the other thing at the community level in one of the last jobs I did before I came back to Palladium was one of the projects that I was looking after was a community-based project in a very remote area in a province in Pakistan. And it was based on door-to-door family planning. There was no government service available over there. These are like tiny little villages of 1,000 people. And MCPR, they exceeded their goal. I don't remember what the baseline was, but they were able to bring it up to above 25% because of this door-to-door community-based approach. They brought in technology, but the women were happy. The social norms were very conservative, but women did not have to travel far. There was a little clinic right down the road. So things like that, I think, are really important. And then also when we look at budgets and when we're looking at community level programs, a lot of the time budgets for governments tend to focus on commodities, yes, but then also at the higher level, they still don't focus enough on ensuring provision of community health workers, at ensuring their capacity strengthening, ensuring issues around access to transport for them, safety, security, all of those things. And I think that it is time that governments, as well as the rest of us, I mean, we can't put all the responsibility on governments. It's time that we all started looking at these sort of very basic ground level needs that need to be addressed. Thank you.
Thanks, Rahal. One of the things I take away from your comment is the experience that you shared in Pakistan is the role of kind of these community health workers, not only as health service providers, but as community change agents. And by going door to door to work through the social norms, it's also the opportunity for that one-on-one, likely woman-to-woman type of conversation about how norms might change. So thanks. Heidi, what about you? What do you think about the community and partner support, and how can we advance positive social norms through better designed health policies and family planning policies?
Thank you, Jay. Yeah, building on what Rahal was saying, I think we do have to start at the top. And remember that it's not only the Ministry of Health, but also the Ministries of Education and Communication that influence women, and especially young women's ability to hear information about family planning and contraception and access it. I think it's important to marry an enabling environment of good social norms with access to services. I think that's very important. Some of the work that we've done in Wish around both giving information and also improving community support is through the use of mass media. And through our partners, DMI, we've been doing broadcasts in all our countries where we work together, demystifying contraception, dispelling myths, reaching out to young people. And this has had a really good recall amongst our clients, over 70%. And it also helps us to reach out to sort of young people. In our surveillance of our services, we've seen variance in women's belief about whether there's support for their decision to use contraception, and unsurprisingly, it was lowest in South Sudan at 70%, but highest in Zimbabwe at 95%. But what we've also seen is that our younger clients and our poorer clients and our rural clients access services most through outreach services and indeed community-based distributors. So we do think that we need to sort of work through these community-based distributors and health workers, as Rahal was saying, to work with people who have unmet need for family planning and to support low discontinuation rates. I do also support Rahal's point around dialogues with men, and through the Wish project, through our partners IRC, we have done dialogues with men and religious leaders in both conservative environments and humanitarian environments like Somalia. And Somalia is the ideal example where those two things intersect. And these dialogues with men and religious leaders have really helped us improve access to women information and support from partners to support that supportive environment to start family planning and then not to discontinue.
Thanks, Heidi. Rahal, before jumping back to you, I just want to comment on a couple of comments that we've gotten. First of all, Julius will be coming to self-care later on in the discussion, particularly around Malawi. So Sandra will be talking about that. I think that there was a comment from Sita about men as partners, that it's not just about women, and we absolutely agree. I think that Rahal will be picking up. She mentioned that, and I think we'll be coming back. And then Ellen's comment about what's happening in the policy environment today with respect to more gender inclusive policies for family planning and reproductive health, and what role is the project playing in advancing that? So Rahal, I think you wanted to add something, and then Sarah, you and I can jump in. Sandra, perhaps you too, on how HP Plus is advancing more gender inclusive policies. Thanks.
Thanks, Jay. I was actually just wanting to add another thought to what I was saying about the earlier conversation, which is that the NPI Expand project is a great example of strengthening a community-based interventions, because we are working with local organizations to strengthen their capacity, to then further strengthen the capacity at the policy level and at the local organizational and service delivery level, which is far better also for longer term sustainability. And when you localize and when you work with local organizations, they have, of course, they're likely to stay on the ground much longer, and they have a far better idea of what the actual needs are at the ground level. So I just wanted to throw that in. Thank you.
Thanks, Rahal. Sarah, about Ellen's comment about more gender inclusive policies, a couple of things that come to my mind certainly are when you look at the results that HP Plus has had over the life of the project, we've had lots of policies that have that gender inclusive aspect. And I think it gets into kind of ensuring that gender equity is enshrined in the policy itself, that in the implementation plan, it reflects women's engagement. It reflects resource allocation for reproductive health. I think one of the activities that really drives this point home really nicely is a gender and governance scorecard that we've developed in years 6 and 7 of the project that looks at a whole of government approach to gender inclusive approaches to policy development and implementation, looking at, I think it was applied in Senegal, Rwanda, and Tanzania. And the idea there is to look at, the policies themselves, but also the governance of the policies to ensure that they are gender equitable, particularly around MCH and family planning, health programmatic areas that are about women, and you can't deny that. And so what's happening in those programmatic areas to advance gender equity, gender inclusion, and coming up with action plans to improve whatever the assessment finds. Do you have any additional thoughts on this one, Sarah?
Yes, I think it's a really timely question. So thank you, Ellen, for posing that. I think in addition to what you were adding, Jay, I've been really struck across the HP plus countries that have had a strong sort of youth engagement, because I think this next generation is really thinking much more egalitarian about services needing to be available for women, but also, as Rahul was making the point, and one of the comments about, really that male engagement and responsibility. And so I think about the youth champions in the West Africa region, in Mali and in Malawi, that are really making sure that we're paying attention to sort of all types of potential contraceptive users, whether they be, sort of younger, older, one type of living condition or another, or male or female, or somewhere in between, such that we're paying attention to people's desire to control their reproductive intentions and how that shifts over time. So I do think that the youth engagement across the project countries has been something that's really helped us think more, be more inclusive about our policy work. Thanks.
Thanks, Sarah. Sandra or Rahul, any thoughts on gender inclusion and how we're advancing them?
Yeah, Jay, I think you've touched, both you and Sarah have touched on the critical side of gender inclusion, but I think policies are now also forcing us to kind of push against those barriers as much. It's not just the gender, but what are we doing with people with disabilities, and how are we including those into policy decisions, and how are we programming for them. And so it's again, working across sectors to really look at what people want and how they want to receive this kind of information and where we can get them, but not just looking at gender, but also looking at these other groups and making sure that people have the services that they want and they need.
Thanks, Sandra. So there's been a lot of questions about self-care. Let me jump into a question about that very topic. One of the few positive impacts of COVID has been a greater expansion of self-care, supporting continuity of care and empowering women to use family planning without having to return to the provider on a regular basis. What kinds of policies and guidelines are needed to advance and effectively implement self-care, and at the same time reduce discontinuation? Sarah, what are your thoughts on self-care and discontinuation?
Sure. Yes, that is definitely one of the positives of COVID, is it just really forced our hand in this respect. I know there are a number of countries that have done a pretty good job about revising their policies in order to ensure that they could continue providing services during the pandemic. Several countries, Burkina, Senegal, Nigeria, come to mind that I've looked at. In Burkina, they added this multi-month advanced provision for pills, for example. They allowed youth to access services with sort of greater, they facilitated that and sort of reduced the parental involvement. Not to say that that's not important, but they were sort of trying to open up the service provision for youth in Burkina. I think also a number of countries have been able to scale up DMPA-SC in this period and self-injection. I'm sure Sandra can talk about Malawi. And I think that the thought that keeps coming to mind around self-care and the pandemic was really brought to mind in Erin McGinn's blog around self-care and digital experience and this concept of convenience. So we've still been talking a lot about sort of getting women to use different contraceptives, but it's also that, right, that continuation. So how do we keep it convenient for them? So it takes a lot of effort to make that first decision to use a contraceptive, and the ability to sort of keep using it is something our data isn't necessarily capturing how well we are keeping women in the system. And then also really enabling those providers, like in Rahal's example of the community health workers in a remote village. How are they able to really address women's concerns around self-care around side effects? Because I think often when we think about self-care, we think about, okay, it's up to the women or the man to use it, but it's still a relationship with the health system. It just changes that relationship. So we need to make sure that, if women are self-injecting, for example, and they run into some problem, how can we make it easier for them to get that consultation that they need through their community health worker, of course, working within their scope of practice, or being able to get back to that facility to get that consultation. I think there's also a role here for digital tools and how that can facilitate some of the communication and making sure that women continue to feel empowered to use the method and overcome perhaps some of those side effects or some of the perhaps objections or cautions that they might be experiencing from family or friends in their community. Thanks.
Thanks, Sarah. As we talk about self-care and think about kind of policies and programs to roll out self-care on a broader basis, perhaps we can keep in mind Christine's question here about what are the thoughts and experiences with self-care in reducing discontinuation across all methods and empowering women to manage side effects. And so I think that, yes, you can get the commodities that you need, but how do you deal with managing the side effects? And I think, Sarah, you alluded to that, talking about the relationship that is ongoing with the health system. It's just a different type of relationship because you're not seeing the provider as regularly. Heidi, what are your thoughts on self-care? I know that this must be a topic near and dear to your heart. So if you could share your insights.
Thank you, Jay. Yeah, building on Sarah's comments, I do think policy-wise, we still have to hold sort of governments and ministries to task on some of these, basic women's rights to say yes to contraception and any method they choose and to continue. And I think we have to work on an enabling environment because it's almost like a continuum in some countries where, once they agree to task sharing, then they might agree to task sharing as low as community health workers who then can be supportive to self-care. So I think we have to maybe move some countries along a continuum. And, as Sarah said, I think, self-care doesn't mean leaving the woman to her own devices. It means ensuring that she still can go back to her health provider or reach a community based health worker who lives nearby for support. But at the same time, digital solutions and media, like, Facebook and chat rooms and phone lines can really help support women if they have questions. They can be quite simple questions or side effects, and they can go back to those. Adding to Sarah's point, in Madagascar, because of the pandemic was approaching, the Ministry of Health allowed the launch of Cyanopress self-administration, and it was held over Zoom by many stakeholders. And I think we don't want to lose those gains that we've gained through the pandemic. Thank you. Thanks,
Heidi. Sandra, you want to share some of your insights about the DMPA-SC self-care efforts in Malawi, or anything else in Malawi about self-care?
Jay, as you know, Malawi is kind of a trailblazer for some of these things, task sharing and self-care, and we're really racing along with all these new innovations that seem to come along. But we also hit a lot of bumps in the road as we go, but we kind of try and learn from that. So when we were introducing the self-injectable, the DMPA, we kind of started in one district which had very poor indicators, and as herd community goes, we had this overwhelming response for women to want to try out the product. And in the trials, we kind of had 199 women who enrolled, and everybody was excited about this. But 2 months down the line, we had totally lost 99 of these women, and that made people sit up to say, this is self-care and everyone's excited, and suddenly we've lost, half the enrollment. What happened? And that kind of made us sit down and re-look at what are the issues that go with self-care, what are the challenges there that go with it. And we found out, the initial response is when, as people have been talking about the relationship, you have a good counselor there and they do their job and everybody's excited about it. But everybody goes home and there's no support for that woman. And she's forgotten kind of how to inject it, or when to inject it, or where to inject it. And she's got nowhere to go and ask for these questions, because it's like 20 Ks or 40 Ks to the nearest facility. So that made us kind of look at, yes, it's one thing to kind of get people on board, but it's another one to kind of put a support system in place. And what does that support system look like? And we, as usual, we overburden the health surveillance assistant, who has 60 other jobs to do. And we pile that onto him, and then you see a lot more women dropping out because he has so many, or she has so many other things to do. And so that one-on-one is missing when it comes to, first-time users and really getting used to the product. And so that, if that is missing from the equation, then you get this large discontinuation at that. And so we kind of re-looked at it and said, who else can support, women? And it's women themselves. So having users themselves who, have the information and live in the same community and live next door to you. In fact, you can chat about these things, when we are fetching water and alike. So taking advantage of those support systems also kind of then increased the likelihood of continuation. And then, of course, we had the issues of provider efficacy, providers themselves not being comfortable with the product. And so bringing them up to speed was another issue that we had to do, so that they could respond to, the side effects. They could respond to the questions that were coming up from the women. So the initial kind of refresher, you'd say, of the existing healthcare professionals on the ground is also necessary. And for Malawi, what we then did when we took it to scale in 2020 was to ensure that, so that we're being more efficient with resources, that this training is within the pre-service, so that coming out, service providers are already savvy on that. So we've learned in terms of adapting, but through, very, as I said, they were hard lessons to learn. But within 3 years, we're kind of at a confidence level. But now we're looking at how do we raise the demand for it. The good thing about the self-care is that it's helped us both in COVID, when health facilities were really grappling to respond to the project. The first services that went were family planning and youth-friendly health services. And by having self-care available, that may ensure that young, people could still have services available. And now, as we're coming to COVID recovery, we've run out of DMPA, the injectable. Malawi is able to then substitute this with the self-care injectable so that we are not losing, and we're not getting that discontinuation between elements. So we've kind of learned a lot around it, but it's really about looking at those lessons and getting onto the lessons very quickly, looking at whether you have policies and guidelines for service providers to really feel comfortable about providing the contraceptive as well, and getting women really that support they need, especially first-time users. Yeah.
Thank you, Sandra. Comprehensive, insightful, based on not just your policy hat, but lots of other hats that it takes to understand what works and what doesn't work. So thanks. And we've been talking about self-care, formal and informal communication. So let's move on to that topic. As we think about digital platforms, what are the opportunities and challenges they pose, and how can they be used to lower levels of discontinuation? And let's think also not just about digital, but in places with limited bandwidth or limited digital access, how can radio, particularly community radio and other mass media, be used to advance quality information while also helping to reduce discontinuation? Rahul, any thoughts on particularly the community radio experience in Pakistan?
Thank you, Jay. So the community radio experience in Pakistan has actually been quite positive. In certain areas where there are higher levels of literacy, newspapers are a big resource as well for information. And with the community radio or even the television, which might not be in every home, but is likely to be at least in the tea shop around the corner, where men especially like to gather in the evenings, it's a great space to set something up, see if somebody can, set up a program, see if someone can be there to run a discussion around it. There have been some ad hoc examples of this kind of work, and as far as I know, they've been fairly successful. But I also wanted to touch a little bit on what you said earlier. Were you saying something, Jay?
No.
Okay.
Go ahead.
About technology, and I think this is something else that came up during COVID, especially in areas where you may not have access to, greater bandwidth, or you might have more power outages. Simple solutions, WhatsApp groups, working with communities with very little or no levels of literacy. These WhatsApp groups that were set up have been immensely successful because pictures were being shared, videos were being shared as a means of, educating and raising awareness. And the other advantage that technology brings us, and especially it's a lot more accessible to younger people because almost everyone has a smartphone. And the other thing is that it provides women with a very safe space in which they can reach out. They have confidential groups. They have access to a provider confidentially, where they can ask questions, including around perhaps side effects, including hesitations they might have that might be pushing them towards considering discontinuation. So I think that's a huge advantage that some of these lower tech solutions can provide us. Thank you.
Thanks, Rahul. I like that idea of using WhatsApp. We see that in so many communities, from very local level to kind of big global networks, as a way to exchange information, and it does reinforce that safe space for talking about family planning. Heidi, your thoughts on kind of the digital or not so digital, radio and discontinuation and self-care.
Great, thank you, Jay. Yeah, I think it's important to look at the methods that are reaching people in each country. And what we've done through the project in WISH and in annual surveys is seeing what the mobile phone penetration is with our clients and what the radio penetration is with our clients, and whether they're smartphones or dumb phones. And I want to give a shout out to Viamo, our partners who in Pakistan and Malawi helped us to signpost services for young people through the so-called dumb phones, through their 123 service. And with the radio programs reaching so many people who are illiterate and people living in the rural areas and the poor, we've also, from those messaging, produced some cards called talking cards, a bit like early learning books, where the community-based distributors interact with clients, and they can press the method and then hear a message about it. And then sometimes where we're able, we leave those within the community, and they create quite a buzz in some of the rural communities. And apart from social media, radio, television, apps and WhatsApp, also call centers in our member association in Sudan in the early days of COVID. They came up with the idea of a sort of a call center, a consultation on the telephone, and then being able to courier some methods to the client, which was very useful, and that's continuing on. So yeah, I think it's also about segmenting the market around digital and media opportunities. Thank you.
Thanks, Heidi. Sandra, I know there's been a lot of use of radio and digital platforms, apps, WhatsApp in Malawi. What are some of your thoughts and insights on kind of the intersection of self-care and this type of technological support?
Yeah, so I mean, to echo what everybody else is saying, the use of the dumb phones, the really basic app that somebody can actually phone in and check in on symptoms or look at what side effects they are by simply downloading an app and getting that information. That's been very powerful amongst maybe urban youth and some unmarried women. But we see more and more that whilst we presume everybody has a phone, the lower down you go into a hard to reach area, it's kind of like one phone per household, and it's usually with a father, and so not everybody can access that kind of technology. And so what we found through working with development radio partners is that community radio kind of steps in to give that voice to the ones that can't access these other basic technologies. And by using community members, so we actually trained, or rather the community radio stations actually trained young journalists to go out and talk to people within the communities and find out what their issues are. And then the community radio kind of addresses those issues in a broadcast and gets, the myths and misconceptions out, ironed out. And then you get all these powerful actions. So from a few radio stations, you see young people going back to the clinic, for example, to restart a method, or you just get, the community galvanized to go and ask about methods. There's been action around, stopping child marriages, building changing room for girls. So community radio is really a powerful medium that we can use to really get some of these issues, and it will address the issues that are connected to that community and not just these broad-based answers or questions that we want answered. So we found it a really powerful medium to use within the digital space.
Great. Lots going on. So very interesting uses of, community radio, WhatsApp, apps in support of self-care, but also to help women continue so that they don't discontinue. We are almost out of time, so what I'd like to do is give our 4 panelists just a brief moment to wrap up and share any closing thoughts they have. Sarah, would you like to start?
Sure. So I guess I would start just by emphasizing that we've talked a lot about different strategies to sort of get women and couples to be using contraceptives. And many of those same strategies are really applicable to helping them continue. And I think we need to change the kind of way we're thinking about it a little bit to really emphasize that keeping them from going out the back door, as you said in the beginning, Jay. Thanks.
Thanks, Sarah. Heidi, any closing thoughts?
Yeah, through preparing for this webinar, I just think it's really important to, hold national programs to account, to policies, to guidelines, to proper rollout that's well resourced. And some of the most important strategies and policies really are around female empowerment and autonomy, right to information, task sharing, and self-care.
Thank you. When you mentioned, Heidi, the holding governments accountable, we have service statistics and all types of things that help us track the uptake and acceptance of contraception. But it's not until we get to, community surveys, household surveys, that we really find out about discontinuation. So perhaps finding better ways kind of along the way to better track that kind of information. Yeah. Rahul, any closing thoughts?
Thank you, Jay. Actually, just echoing and moving forward from what Heidi and Sarah said, I think keeping women's agency and empowerment at the center and the core of everything that we do is absolutely essential. The human-centered design approach is wonderful and has lots of scope. And the other thing is, in terms of women's autonomy, we need to really focus more on women's autonomy at every level, their financial autonomy, their physical autonomy, their ability to make their own decisions. And I think if we really start with that lens, I think we will be able to see more change. Thank you.
Thanks, Rahul. Sandra, closing thoughts.
Yeah, I think really having the right information about the product at the very beginning kind of helps us with this element of how am I going to deal with it as I go along, and really enforcing these support systems, and remembering that even within the married, the unmarried, the youth groups, even within those there are different diversities, and so the messaging will need to be different, and the reaching out to these subpopulations will need to be different if we are going to, really look at discontinuation. So those would be critical, because I think my fellow panelists have really nailed everything else.
Thanks.
Yeah.
So, Georgie, if you can quickly put up the link to the website where the blog series is posted. I mentioned at the beginning, this is not a rehash of the blog, but a point of departure. We've got 8 posted so far, 1 on the data, 1 on improving counseling service delivery and follow-up, another 1 on strengthening supply chain and avoiding stockouts, which is a topic we haven't touched on here, financing to ensure sustained access to contraceptions. Sarah mentioned that at the beginning, changing community ideas around family planning, getting into norms, etc., responding with self-care and digital solutions. And then finally, Rahul mentioned human-centered design. That gets into the new methods. And we'll be finishing up with a wrap-up of the blog series. So first, let me thank Rahul, Sandra, Heidi, and Sarah for joining me today in our policy forum on contraceptive discontinuation. To our audience, I know some of you are jumping off, but we appreciate your taking time. The comments that you've put in, we've tried to address them along the way. So stay tuned for the wrap-up blog. And we, again, appreciate your support of the Health Policy Plus project, our work on developing and implementing effective policies, thinking about financing to make sure that policies are implemented, and good solid governance to ensure all voices are engaged. Thank you so much. Wishing you a wonderful day, afternoon, evening. Bye-bye.
Thank you.